For topics to discuss. We have 3 presenters today, myself included, but I'm going to talk about some housekeeping items first. The first is anyone in the room, if you haven't signed in, please sign in. There should be a sheet on either side. For folks on the phone, please mute yourself if you're not already muted, and the muting is *6. To unmute yourself, if you have a question, press *6 again. And then please do not put the call on hold, because then we will start hearing your lovely hold music. So thank you for that. So I'm Natalie Quitt. I'm the State Public Health Veterinarian. Like I said, today's presentation will be in 3 parts. We have 3 presenters. So I'll start off with a rabies overview, transmission, global and domestic distribution, and then the epidemiology of rabies in Vermont based on our testing data. And then Anita Wade, who is our CSDE Applied Epidemiology Fellow, will talk about rabies post-exposure prophylaxis surveillance in the state of Vermont and her evaluation of the surveillance system. And then following to finish us off would be Christine Matuzovich, Microbiology Unit Coordinator with the Vermont Department of Health Laboratory, and she'll be talking about rabies diagnostic testing. So rabies is a group of RNA viruses in the family Rhabdoviridae genus Lyssavirus. It's a nearly 100% fatal zoonosis. There's been less than 10 documented cases of human survival with clinical rabies virus infection, and 2 of those people, I think, did not have any history of a pre- or post-exposure prophylaxis or vaccination. It's historically significant and feared prior to the control measures that we have today. Virus is present in the saliva of clinically ill mammals, which are the only animals that can transmit the virus and carry the virus. So birds can't be infected. However, certain animals are more likely to carry and transmit the virus than others, as we'll go into. The incubation period for humans is typically 1 to 3 months, incubation period being the time between exposure and showing clinical symptoms. But the range is very wide, from early as 9 days to 7 years. Rabies virus is primarily transmitted through bites, by which virus-infected saliva is entered into a bite wound. Non-bite exposures are possible and extremely rare. Again, you need infective saliva or neurologic tissue to enter into open cuts or into the mucous membranes of the eyes, nose, or mouth. Organ transplantation is actually the most common way of a non-bite exposure, and there have been many documented cases of it. Virus inhalation is also possible, but extremely rare if you aerosolize neurologic tissue, but this mostly would happen in laboratory environments. And it's important to note that virus is not present in blood, urine, feces, or skunk spray, so these bodily fluids are not infectious. In humans, the disease typically starts out as nonspecific illness, fever, malaise, and headache, but it quickly progresses to a prickling or itching sensation at the site of exposure or bite. And from there on, the virus travels from the site of the bite up through the peripheral nerves to reach the central nervous system, where you get lots of neurologic dysfunction. So altered mental status, anxiety when presented with water, difficulty swallowing, muscle spasms, and death is certain within 2 to 10 days after clinical signs appear. Animals is pretty similar. They have a variable incubation period, but typically 3 to 12 weeks. Again, starting with inappetence, malaise, but moves on to central nervous system dysfunction, and death is certain within 7 to 10 days after clinical signs appear. And there's also, since it causes encephalitis, there is an aggressive component to some animals that get infected. So globally, 99% of rabies cases are from dog bites, and this map shows countries where dog variant rabies is circulating. And actually, an estimated 59,000 people die each year from rabies, so it's a very significant global problem. And the highest mortality rate and incidence is reported in India. So whereas dog rabies is the most common variant or rabies virus strain worldwide, we have no dog rabies circulating in the United States. It's been eradicated, but we do have rabies circulating and maintained in wild mammalian reservoirs, and this map shows where these reservoirs are and what they are. So skunks, foxes, bats, raccoons, and mongoose in Puerto Rico. Bats are not shown on this map because they're all over the United States because they fly. And in the United States, about 160,000 animals are tested each year for rabies. About 6% on average are positive. And that does depend on the type of animal. So if it's just wild animals, it's going to be more than 10% positive, but if it's domestic pets, less than 1%. So I know this is a little hard to read, but this is a list of human rabies cases that have been reported in the United States since 2008. And most people, majority actually get it abroad from, exposure to dogs in rabies and canine rabies endemic countries. And those that are domestically acquired are almost exclusively of bat origin, and these are highlighted in red. And then this is the most recent example of a organ donor transmission. And it was a kidney donor in 2011, and the kidney recipient died in 2013. So it's a good example, too, of the long incubation period. And this is the most recent example of clinical rabies survival, and this happened in California. So this list isn't completely updated. There have been 2 other cases of human rabies reported in the U.S. Since the end of this list, and they were both in Florida, both bat exposure as well. So the first was in October of 2017. This person did not seek care after being bitten by a bat. And the second, in January of 2018, the most recent case in the U.S. was in a 6-year-old boy who also got bit by a bat or scratched by a bat and didn't seek care afterwards. His family didn't. Switching gears a little bit. So this list shows all of the animals that have tested positive for rabies in Vermont from 2005 to 2018. And this list is arranged by most frequently testing positive to least frequently. So not surprisingly, raccoons are the most common animal in Vermont to have rabies, because the raccoon rabies variant is circulating on the East Coast here, followed by skunks, bats, and foxes, who are also the reservoir species. Of domestic animals, we actually have cows as the most common animal to be rabid in Vermont, whereas in the U.S. as a whole, cats are the most common one. So I think that's very Vermont of us. And we did actually have a cat test positive for rabies back in, it was May of last year. So this is the same data, just displayed a little differently by year, again, for the same time period. And you can still see that raccoon rabies predominates in blue, and in 2007 was our most recent year with most active rabies. And this was not just a regional increase, this was also, there was about a 5% increase in the United States as a whole that year from the year before. So these are, rabies is actually found throughout the state of Vermont, as these maps demonstrate. So the map on the left is for the time period of 2005 through 2018, and the map on the right is just for 2018. So the towns shaded in green indicate how many total animals have been submitted for testing from that town, and then the purple dots indicate just the positive. So larger the dot, the more positive specimens came from that town. Darker the green, the more specimens were submitted. So you can see there's a lot of submissions from the northern part of the state. This is largely due to enhanced rabies surveillance that is done by USDA Wildlife Services. And there also might be more submissions in areas where there is higher human population because there's more human-animal interaction. So we get submissions for rabies testing every month of the year, but not surprisingly, more so during the summer months between May and August. So that green, I guess that's a light green color up there, are the negatives, but the darker green are the positives. So we do get positive specimens every month of the year. And just to display the same data a little bit differently, this is the proportion of tests by month for this time period. And again, the darker green are the positives. So as you can see in the winter months, we actually have a higher proportion of rabies positives. And this is largely due because we have less submissions, but these animals that are out and about in the winter might actually, they're acting abnormal because they're sick. So that leads me into why do we test to get this surveillance data? So we prioritize and test for a few different reasons. The highest priority reason to test animals for rabies is for possible human exposure, and this helps us identify if the person exposed needs post-exposure prophylaxis treatment for rabies. Following that, we get a lot of specimens that may have exposed domestic pets or livestock, so that's also good to know. So we don't want that domestic pet or livestock animal to get rabies from the wild animal they've been exposed to. We receive specimens for diagnostic purposes, usually from veterinarians, and then surveillance. We get a lot of specimens for that through USDA Wildlife Services. They work with fish and wildlife trappers to make sure that the rabies vaccine bait drop is being effective in preventing wildlife rabies in the state. And this bait drop occurs every August in the northern parts of the state to help vaccinate wildlife. So to summarize, this is how many tests we get by reason for tests, only the positives here. And by far, actually, the most common reason that a specimen is testing positive or reason why it's submitted are for the animal's contact with domestic pets or livestock, which is not surprising because pets and livestock tend to spend more time outdoors and might be in contact with a rabid animal before a human. So just a bit about prevention. So while rabies virus, once clinically ill, is 100% fatal, it's highly preventable with timely administration of post-exposure prophylaxis, or PEP. And the Advisory Committee on Immunization Practices develops guidelines on when to give and how to give rabies post-exposure prophylaxis. And this is published in CDC's Morbidity and Mortality Weekly Report. And the most recent guidelines were in 2010, which recommended a reduced schedule, a 4-dose schedule, which previously used to be 5 doses. And I won't go into this regimen in too much detail, but basically rabies post-exposure prophylaxis consists of 2 parts, the first being rabies immune globulin, and this is injected into the site of exposure to help neutralize virus so it doesn't travel up to the central nervous system and tries to neutralize it before vaccine has time to be effective. And so for previous unvaccinated patients, they do get RIG and 4 doses of vaccine, but if you had been previously vaccinated, you do not need RIG, and you just get 2 doses of vaccine. So the decision to give PEP is a complicated one, as demonstrated by this decision tree, and it largely depends on the type of animal exposing the person. We know they're not all created equal. Was the animal acting strangely? Was the bite provoked, unprovoked? The local rabies epidemiology, so what are the circulating strains? And then where in the body was the person bitten? If they were bitten on the head, neck, or face, that elevates the urgency. You might have a lower threshold for giving post-exposure prophylaxis. So what we consider rabies exposure is any bite or scratch from a wild mammalian terrestrial carnivore. We consider that a rabies exposure, even if you don't have the animal available for testing. So these are the rabies reservoirs of raccoons, skunks, foxes, and bats, but we also, other animals of concern are bobcats, coyotes, otters, fishers, and woodchucks. I should note that small rodents and rabbits are less likely to be infected with rabies, and there's been no documented cases of human rabies associated with exposure to these animals, so they're of lower priority for PEP and for testing. So this is just a recent example of interagency response to rabies in the state of Vermont. In December, there was a strange behaving bobcat in the Hartford area that actually attacked 3 people, and then it was euthanized by Fish and Wildlife, and we tested it for rabies, and it was positive. So all 3 people who had been exposed to this bobcat received post-exposure prophylaxis. And also, it was the media attention surrounding this was helpful because there was actually a third individual that might not have come forward to get care had he not known that it was rabid. So that's just a good example of why we have animal bites and rabies post-exposure prophylaxis as reportable in the state of Vermont. Animal bites are reportable by physicians, and it could be self-reported by bite victims, largely so that, and they're reportable to town health officers, largely so that they can follow up with cats and dogs to make sure they stay healthy for 10 days, and if they are, they were not shedding rabies virus. And post-exposure prophylaxis is reportable to the state, and that's so I'll actually use this moment to pass it on over to Anita Wade, who will talk more about post-exposure prophylaxis and her evaluation of this surveillance system. Thanks.
Good morning. As Natalie shared, my name is Anita Wade, and I'm a CSTE fellow here at Vermont. And I'm going to go over what PEP looks like in Vermont and the surveillance of it. So to start, I began with an evaluation of RPEPSS. And RPEPSS stands for the Rabies Post-Exposure Prophylaxis Surveillance System, which is a mouthful, which we call it RPEPSS, which is a passive surveillance system. So this means that we are receiving reports from healthcare providers that submit them. We're not actively going out and getting them from healthcare providers. So the purpose of having a surveillance system to track PEP is to track the trends. We want to see, as Natalie showed, which animals have rabies. We want to be able to see which animals have the most are causing the most exposure to humans for rabies. And we also want to ensure proper utilization to make sure PEP is a very expensive series of vaccines. So we want to make sure that it's being used properly and only when necessary. And in addition, tracking complies with the reportable and communicable disease rule, which requires PEP to be sent into the health department whether or not the animal was positive for rabies. So why evaluate? First of all, it was time. The system had never been evaluated, so we wanted to make sure we knew that what's happening in the doctor's office is also what's getting back to us and that we're getting all the information we should. We wanted to look at different surveillance system attributes, such as simplicity, how simple is the system to use, what's the quality of the data, is it stable, is it acceptable, do people like it, and how quickly do we get that information back to the health department. In addition, the major reason for taking on the evaluation was to be able to provide recommendations for improvement. So briefly, I'm going to go over the methods, but if you have more questions, feel free to ask them during our Q&A session at the end. But we used 3 data sources to compare to see if RPEPSS was getting all of the information that we thought we should be getting. So we used Vermont Immunization Registry data and the Vermont Syndromic Surveillance System, which receives information from emergency departments and is searchable via the chief complaint field. So it's a text search. And the time frame we looked at was August 2016 to July of 2017 to have 1 year of data. We used the CDC's updated guidelines for evaluating public health surveillance systems, and first started by looking at what the flow of information was from an exposure to getting into our system. So as Natalie showed that big decision tree, if an individual is exposed to a potentially rabid animal, they consult with their healthcare provider. If there's no confirmed exposure, there's no need for PEP. They can go home and save a lot of money. But if there is a reason for PEP, they receive treatment, and the healthcare provider, or in some cases the pharmacist, depending on the hospital, is required to submit that information to us. So it comes to health surveillance, and at the time of this evaluation was going to the state public health veterinarian, and it still does that, but they're responsible for tracking PEP cases in RPEPSS, and then following up as needed. So if they see that certain information is missing or want more information, they can contact the healthcare provider. So I'm going to show next an example of what the data looked like when we first started this evaluation. You'll notice that there's several red circles, which are showing that there was some missing information. We had, on average, about 3 out of the 11 required variables being collected consistently, and there was no standardized form for hospitals to send this information in. So knowing that there were some holes in the data, we wanted to compare what were the actual number of cases we were getting. So there's a lot going on here, but I just want to note that the x-axis goes from August to July. So as Natalie showed that those summer months have higher frequencies of animals tested, we also see that for higher cases of people receiving PEP. The blue represents RPEPSS, the green is the syndromic surveillance data, or ESSENS, and the brownish color is IMR data, or immunization registry. So just looking at RPEPSS, we found that we were getting about 50% of the cases that we saw in these other two data systems, showing us that there was some work that had to be done on both the quality of data and the education of providers to be sending it in. So based on this brief comparison, we came up with a few recommendations. First of all, that the data should be organized and collected in an electronic database. This allows for better tracking and also just helps keep things consistent. We also wanted to evaluate the usefulness of tracking rabies PEP by surveying other state public health vets. We wanted to know if other states are also looking into this and why they're doing it. And we wanted to create and disseminate a standard form to all hospitals so that they had instructions on how to report and why they needed to report. So I'm happy to say that the current status of most of these recommendations is either completed or in progress. Currently, reports are entered into EpiInfo. A survey was disseminated to other state public health vets to hear from them about what they do in their areas. And a standard form was created and disseminated to healthcare providers. In addition, there's some really interesting reading material online. A new Vermont Rabies Control Resource Manual was published on the VDH website and includes a lot of information about when to give PEP and rabies control within Vermont. So just as I mentioned that standard form, the form on the left is what was used by one hospital at the time of the evaluation, and the form on the right is what we've updated it to and is now available for all hospitals online. So after going over the evaluation of the system, I'm going to dive into some of the surveillance data that includes pre- and post-evaluation information. The areas I'm going to focus on is kind of the who, what, when, and where, who is exposed, and what kind of animals have been leading to exposure, as well as where the reports are coming from primarily. So I just want to note, you'll see a big jump between 2015 and 2016 in the number of cases, and that's because one hospital during the evaluation said they had a lot of forms, that form that I showed previously, and asked if we wanted that information, and I said, absolutely, please send it, and so they got added into RPEPSS, backdated. But in 2015 to 2018, there were 342 cases that we tracked of people receiving PEP. So looking at who was receiving PEP by year, this is broken down just by adult versus child. So an adult is anyone 18 or over, and about 84% of the PEP cases come from adults. And this was pretty much, the proportion was the same from 2016 to 2018. Looking at the species related to PEP reports, this is not surprising after seeing some of the data that Natalie showed, but about 50% of all reported exposures are related to bats. The second highest is dogs at about 15% of cases, and there are a surprisingly high number of monkeys, but we also see cows, woodchucks, horses, and some of the other animals that Natalie already mentioned. So looking at this a different way, just domestic versus wild, on majority, most of the animals are wild that people report being exposed to. I will note that domestic includes cats, and sometimes cats may be stray or wild, but they were categorized as domestic, so this proportion could be a lot higher. The route of exposure, unfortunately this information was not available in the data we received pre the new standardized form, but hopefully we'll receive more complete data moving forward. But a majority were in the other category, and other is composed of bat exposure, so a bat in a room where people may be sleeping was about 90%, 8% was exposure to a rabies-positive animal, and 2% was other. The second highest category was bites, making up about 70 of the cases of PEP. So we're really drilling in the seasonality related to rabies, but June, July, and August was about 50% of PEP reports were in that time frame. And the two lowest months were February and November, and about 43% of the cases in those months were related to a bat exposure getting into the house or a sleeping area. So we wanted to look at where people were receiving PEP. About 67% of the reports came from UVM, And the second highest category was Southwestern Vermont Medical Center with about 8% of the reports. This is not to say that there's not rabies. As Natalie showed, there's rabies all over the state, so this kind of highlights that we may need to do better education of reporting practices for these other facilities. But moving forward, it'll be interesting to see how these numbers change. So in summary, there were over 342 cases of PEP reported during 2015 to 2018, and the mean was about 85.5 per year, with the average, with the median being 97.5. And we expect that this is probably closer to 100 to 120, just looking at our comparison to the other two data sources. PEP cases were reported to over 16 different from exposure to over 16 different species of animals, 50% of which were bats, and 50% of the cases occurred in June, July, and August, with the majority of them coming from UVM. The next steps for PEP surveillance are to ensure that providers are educated on reporting guidelines and that they know about the resources available on the VDH website now, as well as making sure that PEP is being used properly. It was about $7,000 to $21,000 for the series of 4 doses, so it's a pretty expensive medication. But next, Christine is going to come up and discuss testing of rabies, which plays a really critical role into determining when to give PEP.
Okay. I am Christine Matusevich. I'm with the State Health Lab, and I'm the microbiology unit coordinator. And I have to give everybody warning right now. I have graphic images, and if anybody is offended by blood or tissue of dead animals, then you might not want to stay. Look away. And if you feel like leaving, for the people that are here, feel free. I won't be offended. So let's just jump into it. So rabies is diagnosis is dependent on animal testing, which is pretty rare for most of the things that we treat people for. And these are pictures of animals that we have received over the years. Oftentimes we'll get baby animals, which is the first picture, and it's because people find baby animals and they're cute and they want to take care of them, and then one of them dies, and then they have to euthanize the whole litter, which is really sad. It's kind of a sad rotation overall. But the middle picture is a flying squirrel, which most people probably haven't seen. We don't get very many of them. But excuse me. The third picture, sometimes we get animals that have been skinned, and these are usually from taxidermists or trappers. So these are very shocking for us, but they're pretty rare, which is good. One of the other things that we do get are bats, and we get juvenile bats. Oh, uh-oh, where'd it go? There it goes. Wrong button. We get little baby bats as well as adult bats. We had an Arctic fox, and I don't know a lot of the history on this Arctic fox, but it was a person that had 2 of them, and because you're not supposed to have Arctic foxes, they had to be euthanized, because no one else would take them on. So. And then the last picture is the bobcat that Natalie was referring to, and this was a very large cat. We work in a biological safety cabinet, which keeps us safe. And the cabinet itself is about 6 feet long, and this cat must have been at least 3 feet long. I mean, the feet were sticking out of the hood, so it was incredibly large. So the process for testing, this is the workflow. We have the necropsy, and then slide preparation, tissue fixation, tissue staining, and then we read the slides. The first picture, we have the tools of the trade. Starting off with just round filter paper, which we use for blotting slides to remove excess tissue. That jar, that kind of tannish jar, is a Coughlin jar, which is what we put our slides into for tissue fixation. And then just the jar with the green cap, we just put tissue in after we do the testing. And then the metallic tools are the actual tools that we use during the necropsy. So we have a hammer and chisel, nothing fancy. A set of rongers, which are like those kind of scissor type things right here. We also have large and small forceps and scissors, and we also have a scalpel. We have a disposable scalpel and one that we can reuse. And then the other picture to the right of that is a grapefruit spoon, which was actually ordered from Amazon, something that you can use every day. It's used on the larger animals like the livestock, just because I'll show you how we have to go into that. And surprisingly, no one has left the room here. So we're going to start getting into some of the more gruesome pictures. So what we need from the animals are the brain tissue. So what we accept is cerebellum and stem, and hippocampus and stem. And in the upper right picture, you can see in the white square is the cerebellum, which is what we need. Underneath the cerebellum is the stem. So in the bottom picture, you can see the stem that resides underneath the cerebellum. On the picture that's below the text, you can see an image of the hippocampus. The hippocampus isn't something that we normally go for. We would only go for that if we couldn't get the cerebellum. Sometimes the animals come in, the brain is damaged, and the cerebellum might not be quite adequate, so we can always go for the hippocampus. And it's just a matter of, gently slicing into the cerebrum, and this little pocket opens, and there it is, and then we just remove it. So what we collect really depends on the size of the animal. For small animals like bats, we're going to collect the whole brain just because it's so small. It's literally like a pea size. For medium animals like the dogs, cats, skunks, raccoons, we'll collect the stem and the cerebellum or the hippocampus if we can't get it. But we always need stem no matter what animal we test. For the livestock, we have stem and cerebellum. And then for the USDA specimens, they actually submit to us just it's more spinal cord. I don't want to say it's them because of the process that they use, but they actually process the samples themselves. And it's part of the USDA Enhanced Rabies Surveillance System. They track rabies throughout the state, and I can get in score when I show that sample. So the first sample that I have here is a bat, and you can see in this image that the skull cap is removed, and we just need to use some scissors for that because the skull cap is very thin, so it's easy, and bats are really easy. And then we just remove the whole brain for slide preparation after. The next animal, it's a medium-sized animal, and I see some faces that are kind of squinting. So what we need to do is first we have to cut away at the skin. So we'll do a T incision, starting at the top between the ears and then down. Then we cut away the skin and the muscle, and then we have to actually just cut through the skull itself. So with that, we use the hammer and the chisel, and we put the chisel on the skull, resting it on it, and then just start hammering away. So in that picture on the right is where the microbiologist is starting to cut away at the tissue, and it's an upside-down U. So she'll go across and then down the sides. And we have to pull the skull cap back. So the next image shows that. This is the picture of the cerebellum, which we would remove, and then we would set aside. And then underneath the cerebellum is the stem. So for a large animal, such as a cow, this is actually one that we had last week. This was a down cow that was going to slaughter. And once the cow is down, then they have to submit it for rabies testing. This is actually about a 55-pound head. So it's definitely a two-person job to get it in the hood and out of the hood, especially bagging it back up because it's just messy and it's heavy and it's awkward. But we have to go in through what's called the Foramen Magnum, and that's basically just a hole in the base of the skull. So on the image on the left, you can see the spinal cord that is leading into the skull itself. And then you have to visualize it. Because we normally work with the skull facing up, the top of the head is facing up, this is opposite of what we're normally used to. So the head is faced down. So the cerebellum is actually beneath the stem now. So it's opposite of what we normally do. So this is where that grapefruit spoon comes into play. You're never going to look at a grapefruit the same way. So because there's a membrane inside where the spinal cord is, we actually have to cut away with a scalpel, and then we just take that grapefruit spoon and we just have to kind of scrape along the skull cap because there is a membrane there, and we have to cut away at some nerves. And then hopefully if you do it right, you can just kind of pop it all out. This cow was kind of in bad shape. I don't know why. It was a couple days since we found out about it to the time we received it. So the cerebellum itself was not in the best of shape. It didn't come out like in one solid mass. But it's still okay to test because we can just take representative portions of each of the pile of cerebellum there and test that. There's also a picture of the OBEX, which we are required to submit to USDA for BSE testing. And the stem is right beside that. So these are what we get for USDA samples. They just submit a bag to us with sport files, and in each of the sport files is a little sampling of spinal cord / stem. They do all of the work for us, which is really good. They have freezers scattered throughout the state, and trappers and game wardens will deposit animals that they find or nuisance animals, and they will go throughout the state, open the freezers, and basically remove the head from the animal. And with the spork, it's kind of a sharp spork. They will just try to remove some of that spinal cord for us and put it into the container, which is a huge time saver for us because they submit about 20 a week, and to do 20 extra autopsies or necropsies would be very, very time consuming. So once we have the tissue, we make our slide preparation. So we have to have a cross-section of the stem always. And we also take a cross-section of the cerebellum, and you can see in the image, the first image that I drew a blue line to represent where we would cut, and we would slice right down through it. And then we would actually have to cut it to fit the circular rings for the slides. So in the right image, you can see the microbiologist is doing a touch impression of the tissue. So we would do that for all parts, so all of the stem and all of the pieces of the cerebellum. So once that's done, they're allowed to dry a little bit, and they're placed into a sport file with acetone, and then they're fixed. The minimum time that we can fix is about an hour, but we prefer to do an overnight, just because there's difficult animals such as cats that there tends to be some non-specific fluorescence, and the overnight soak tends to get rid of a lot of that. So it's helpful. We prefer to do an overnight soak. But if it's an emergency, we need the result, we can do it in as little as an hour. So after the overnight soak, we take the slides out and we allow them to dry. And then we put them on a slide tray, and we apply 2 different conjugates. And the conjugates have monoclonal antibodies that are against rabies. And we use 2 different conjugates just to ensure that we have coverage for all of the different variants of rabies that are found in the U.S. So with the 2 conjugates that we use, that covers everything. So with the tissue that is on the slide, we add the conjugate, the first one, which we call a DFA-3, to the first impression. And then we add a second conjugate, which we call DFA, to the second impression. So that's done for all slides that we have in the run. So if rabies is present, monoclonal antibodies that are in that conjugate will bind to the tissue that is on the slide. And that antibody has a fluorophore bound to it. It's a FITC, fluoroisothiocyanate. Say that 10 times. So that is bound to the antibody. If we have the antigen there, we're going to have an antigen-antibody complex. So that actually incubates for half an hour. And then after the half-hour incubation, we wash. Anything that is not bound will get washed away. So if rabies is present, the fluorophore will be exposed to UV light with our microscope. And the UV light will actually cause an excitation of the fluorophore. And when that happens, it releases light at a different wavelength. So we see green light. And it's a very bright fluorescence. Pretty sure that the screen here probably won't do it justice. And obviously, if that antigen-antibody complex isn't there, then we're not going to see any sort of fluorescence. So this is what our little room looks like. We have our microbiologist, Alan. I don't know if he's listening, but he's reading slides. And the picture on the left obviously is in the light, but we need to read this in the dark, so we turn the lights out, and you can see the image on the left or the right has blue light, the UV light that we use. So when they actually built this new building, that black screen that's to the in the upper left corner was a window. It is a window, and we went in there and we're like, this isn't going to work, so they installed this dark screen, and it's amazing how well it blocks the light up. So reading slides, we have a grading system, and there's intensity and then there's distribution. So for the intensity, 4+ would be considered a glaring apple green fluorescence. 3+ is slightly diminished stain intensity, and then we have 2+, 1+, which is a dulling in the intensity. So for the staining distribution, we have 4+ would be a massive number of large, small inclusions that are present on all areas of the slide, the impression, the smear, I call it multiple things. 3+ would be inclusions that are found on most of the fields, but it can vary. 2+ would be at least in 10 to 50% of the fields, and usually just a few inclusions per field. And then 1+ would be inclusions present in only less than 10%, so it's pretty rare, only 1 to 2 per field. And when I say a field, when we are looking in the ocular lenses of the microscope, it looks like a round image, like in the picture there, and that would be considered one field. And then you would move to the next field just by, like, if you have the top is your starting point, you would keep moving down until it reaches the bottom. Then that next area is your next field. So we read about 40 fields per smear. So we're reading a lot of fields. And in this image, if you're wondering what that line is, it's just a bat hair. Sometimes when we're making the slides, hairs get on there and they fluoresce. So this is what the image on the left is what a positive would look like. And neither one of these screens really do it justice, but it's really, really pretty. It's I know, I probably shouldn't say that, but it's like a really, really bright apple green fluorescence. It's like looking at the stars at night that are glistening, or like, anybody remember the light bright and how bright that was? Imagine a lot of little light bright light bulbs all over. And the size of the fluorescence can vary, so it can be very large or it can be dust-like. And when it's dust-like is when it's very difficult to make a determination if it's actually something or nothing. The image on the right is what a negative would look like, and yes, it looks very dark. So nothing there. We do run into issues with smears. Sometimes for various reasons, things will trap the conjugate and cause what we call a non-specific fluorescence, so it's not true rabies, but that would still require repeat testing. So the image on the left, you can see just sporadic fluorescent specks around, we like to call them, just a bunch of specks. The image on the right is yellow staining, so it's not the apple green, and these are CDC slides, and the case with the yellow staining was actually a case where it was a technician that was new to reading and actually called that a positive, and 150 people ended up getting PEP in this case, and it was not an actual positive. So we do get a lot of training because it's a lot of eye training, and you have to be able to determine true fluorescence from not, because people can die. It's a very serious rotation, a very serious test. And you have to be spot on with everything. So this is something that we often see, atypical staining. If we have 5 slides, that's 10 smears, and we have one patch like this, we will repeat it because we have to be absolutely certain that it's not rabies. The image on the right, the atypical staining of bacteria, they can pick that up too, but it's pretty obvious that it's not actual staining. But again, it's all in eye training, and people that are on the rotation definitely have to feel comfortable. And for all human exposure cases, we do have 2 people read a set of slides just to be certain, because this is a fatal disease and we want to be certain that we get it right. So, as I had said earlier, we do need a complete cross-section of the stem in all cases. That's just because in rare cases, the way that rabies works, it actually goes up, it can go up one side of the spinal cord, go to the brain, and then on its way back down, it can go down the other side to the salivary glands. So I've only seen like 2 instances of a case like this where you're seeing nothing, and all of a sudden you're seeing this fluorescence. It's like, oh, whoa, this is actually positive. One of them was a bat. So, and then this, my final slide, is the Legendary Chupacabra that was found in Vermont in 2002. And I hadn't been testing too long, but still. Any guesses as to what this animal actually was? Anybody?
raging coyote?
No, this is actually a fox. And I opened up the bag, and we try not to take the animals out of the bag because we deal with a lot of nastiness, and this is one of them. We will always test everything because if it's positive, it's positive. But if it's not positive, then we'll just say it's inconclusive. But we deal with maggots and fleas that jump out, so we try to keep the cadaver bag open just a little bit. And as soon as I set this thing out, the fur just sloughed right off of it. The stench was horrible. The picture, that is a picture of me. Good thing I have a mask on so you can't see how much I've aged. But my eyes were watering because this thing smelled so bad. I mean, the things that we put up with, for me, the fleas and the maggots are probably the worst. But, so, yes, this is what I would call the Chupacabra that was in Vermont. That's all that I have.
I think we'll all just gather up front for any questions. And if you're doing questions from the phone, remember to press *6 to unmute yourself. And I think there is a microphone back there Will has that he can pass around. We'll try to repeat questions, though, so folks on the phone can hear it. Well, yeah, I wanted to hear on slide. So any questions in the room, or Ruth?
So I'm a veterinarian.
Microphone.
So sometimes I would be, I'm a veterinarian, so sometimes I would be in a position of submitting samples. So it doesn't really matter how badly decomposed the animal is. I mean, you're looking at that fox was
For
pretty
human
bad.
exposure cases, we would do it. But if it's just a surveillance, no, we would not do it. Yeah.
Yeah, so there is a limit to I think, viability of the specimen. For testing at the lab, I think what we usually say, like 7 days of non-refrigeration, maybe.
We've had people, after the fact, they buried an animal and then they thought about it and are like, oh geez. So we've had people exhume them and submit them. So it really, I think, depends on the situation.
Yeah. And I should mention too, there's Christine probably knows more about it, a new PCR test that is being validated that actually can be done on quite compromised specimens, but it's not widely available yet. I think they do it at Wadsworth Lab in New York State.
Yeah, they just came out with it, so it hasn't really been incorporated into like a CDC algorithm, which is what we follow. So once they do that, I would have more faith in using it, but because it's such a fatal disease, I'm sorry, I'm not comfortable doing PCR right now because, the whole process of PCR, you're extracting the RNA from the sample, and it's like, is the sample really in there? You can't see it. I can see this. So PCR is good technology, but for something so fatal, I'm just not comfortable using it.
I think there were some behind.
Great talk, everybody. I have two quick questions. First one would be better if I had actually timed my question with some of the slides, so the answer may have been on it. But bats have really had it rough lately, and it's throughout the country and certainly in the Northeast. Is the diminishment in their population being reflected in the data we see about numbers of people who are reporting incidents with bats that require all this testing?
Yeah, I have only anecdotal information about that, and speaking with game wardens who have been, out in the field and working in Vermont for many years, they do note a significant decrease in the high points in time. July is a big month where they would see a lot more than what we have been receiving during that time of year, and that is because of the decline in the bat populations. And I can't, we received so many bat specimens in July. I can't even imagine how it would be in years where the bat population was healthy. Maybe, Christine, you've noticed a difference over time. I just have heard from people who are doing the submissions that it's gone down.
And my second question is the bait drops. That's kind of a public health measure, as well as, I guess we'll call it an animal control or some other agency's initiative. What do we know about the impact that's had? And is it worth continuing to do it? Do we see some sustained impact from the start? Do we see incremental, greater impact over time?
Yeah, USDA Wildlife Services has better data on that, but again, anecdotally, I mean, just looking at the maps over time, how many more positive specimens that used to be collected in the northern part of the state, and now we're getting, maybe only a handful that are collected within the bait drop zone, and most are bats, and they fly, and that's because they're not targeted by the bait. So I feel like it's effective, but I think USDA is being cautious in saying that just yet. I haven't seen any reports come out saying that it is, because we still want to treat every rabies vector exposure to a human as a possible rabies exposure. We want to give a false sense of security to people, so in case they are carrying rabies, because it is still reintroduction is still a possibility. You hear about raccoons from a rabies endemic area coming in on garbage trucks, that kind of thing. So, again, anecdotally.
I do know that they have changed the vaccine that's used in the bait, and I believe USDA had said it was 70% more effective than the previous one, and it's actually doing a really good job at keeping rabies at bay. But like she said, we still need to continue the surveillance, and maybe at some point it will be gone from there, but we are trying to keep it from advancing into Canada, because right now they don't have it.
Any other questions?
Are the 3 people that got attacked by the bobcat fine now?
So far as I know, yes. And I did make sure to follow through and make sure they did receive confirmation from the hospital that they did receive all their doses, and they have. So, yeah.
I have a question. I don't know if it's a quick answer, but because the rabies is transmitted through the saliva, can you speak briefly, Christine, to why there isn't testing that can be done on the saliva? Seems cheaper and less messy.
I don't believe it would be sense enough. I don't think there's enough virus that would be reliably detectable in saliva.
My question is, how many cases of people who call and say, I see a rabid fox, or I'm looking at this thing and it's really mangy, and game wardens say, I'm not going to go out, you can shoot it yourself, but you got to bury it 3 feet deep. At this time of the year, you can't be burying it 3 feet deep. Well, where is the checkpoint on that?
Yeah, I guess it depends on the game warden you get and their priorities at the time. They certainly prioritize any possible human exposure, but if they've determined that there's absolutely no human or pet exposure, sometimes they can't come out right away on a call to collect an animal, and that animal is, chucked in the woods or something. So yeah, it is. Our surveillance isn't perfect, depending on what can be collected and when. So again, that's anecdotal. So.
Hi, I'd be curious to know how you are changing behaviors in the hospitals to get them to fill out that form.
Yeah, that's a tough one. I think there still needs to be a lot more work on that and outreach, because it's only improved somewhat as far as more submission, of the reports. But I don't know, maybe Anita could speak more to that.
I know UVM, who we got a lot of reports from, they have a system where if someone comes in and needs PEP and they request it, the pharmacist, they have to fill out that form to get the drug from the pharmacist. So they kind of have like a really good system set up, and the pharmacist then just scans it to us, which is really nice. I don't think it's the same at every facility. I know during the evaluation I called people and they were like, what do you mean it's reportable? Like, why? And yeah, it's definitely a challenge because people have so much going on to have one more piece of paper to fill out, but yeah.
You said there was one case of a person who survived from rabies, and I was wondering if that was due to the prophylaxis or how they were able to overcome the disease.
Yeah, there was just one, I know there's been at least, I think, less than 10 documented cases of survival, but that one was just it's since 2008 in the United States. There is something newish in the treatment for rabies called the Milwaukee Protocol. And essentially, they induce a coma in the patients to try to reduce the effects of the encephalitis on the body. And actually, I'm going to call out Veronica here. She actually met a rabies survivor in Michigan, which is very neat. I will say, too, that there are long-term neurologic deficits and problems in the people that survive rabies.
Yeah, so I met one of the Milwaukee Protocol survivors, I think the one that the Milwaukee Protocol started on, and she had to relearn to walk and talk and go to rehab for years, but she's doing well and is married and I think is a teacher or something.
She does outreach, right, for BAT?
And does outreach, that's how I met her, is at a BAT festival.
And she still likes BAT.
I don't know if you guys will know the answer to this question, but because the PrEP is so expensive, and I know there's obviously a vaccine for like domestic animals, do we know why there isn't a vaccine for humans? Like, I get it's not super prevalent, but because, you know, when you get it, it's deadly and so expensive, I'm wondering.
So there is a vaccine for humans. So it's the same vaccine used for post-exposure is used for actually pre-exposure prophylaxis. However, it's not recommended for the general population, even in rabies endemic areas. It's only recommended for individuals that their line of work puts them into veterinarians, laboratorians, game wardens that put them at risk for exposure to rabies. So, yeah, it's still expensive to get, though. Yeah.
I always like to tell people that because I've been vaccinated, if I'm with them and a raccoon comes up, I will defend them.
Any other questions in the room or on the phone? Oh, we got it, one in the room.
Anita, how were you able to differentiate the dose 1 rabies in the registry that were pre-exposure or post-exposure doses?
So I wasn't able to. So that's definitely one of the limitations, that you can't tell if it was given pre or post. The fact that those numbers were pretty close to the ED numbers that we saw in Essence was kind of nice. Oh, well, I guess one thing, I did restrict to only looking at hospitals. So ideally, it's hard to get the vaccine in general. I'm not sure if you went to an ED, like if you go to the ED when you get...
I got mine through the health department.
Through the health department, yeah. So I restricted to just looking at hospitals to try and get at just the people that received
and they're entering the rabies immune globulin as well, so if it was paired with that, it would be...
Yeah, however, another limitation is that persons who have received vaccination or pre-exposure prophylaxis in the past don't get rabies immune globulin, so that's another difficulty. Okay, if there are no more questions, we can wrap it up. Thank you so much for joining us.